Hi, good afternoon, everyone. At first, when I entered the room, it was like barely a few people, so I got worried. But I'm so glad that the room is filling up and I see a lot of familiar faces. Thanks for coming, and thanks for the organizers for giving me the opportunity. Okay. Yes. Okay. Am I blocking the slides? Okay. Okay. So just before I start, a quick one. I was actually assigned a totally different topic because I usually am very, very passionate. Usually it's not the right word, but I'm very, very passionate about life after cancer. So a lot of the things that I do are survivorship, living well, and things like that. But this is something very close to my heart because I started as a clinical epidemiologist. And a lot of the things that we do, we analyze very simple data. The analysis is so not complicated, like it's not fancy analysis, but they yield very, very useful insight, which is why I'm very passionate, and this is something that I wanted to share with a lot of you to just show how with very simple data, we can come up with very meaningful insights that can be very, very useful for cancer control. So that's the background. So I'm going to talk about the trends of breast cancer over 15 years, thanks to my study team. And the study was actually funded by Zurich Pharma, so thank you to Zurich Pharma. It has been accepted in JCO Global Oncology. So it should be coming out in the coming weeks or so. We just sent out the proof. Can I have the next slide? Please, the next one. Okay, so I think I'm going to skip this because everybody in this room knows that breast cancer is the most common cancer in Malaysia. 1 in 5 cancer diagnosis is women with breast cancer. So it's women, not men. It is less common, but it happens. And there are ethnic variations, and the incidence peak after 35. The next slide, please. And how are we doing in terms of survival? I think this one I want to pause for a while. This is data from the National Cancer Registry, not the most recent data, up to 2016, where we looked at 5-year survival. And when you see their relative survival, it is an estimation of breast cancer specific survival. And we are not doing very well, so but less than 70% really. And how do we fare internationally? You see that we are right below Singapore, just above Thailand, and you see the difference between Singapore and Malaysia, 80% to less than 70%. Then why is the case? A quick look here, you'll see, of course, there are age differences, but it's a lot to do with the stage, right? And we have a lot of advanced cancers, which is why probably, I'm just saying probably because we also have many, many reasons, but stage remains one of the biggest problems that we have. But also access to cancer therapies, newer cancer therapies, life-saving therapies is also a problem. So how do we improve? Can I have the next slide, please? So how do we improve? We have some data, it's from the National Cancer Registry. There are some indications we never really compared and see whether the survival improvements or the stagnant survival trends are really about stage. So what do we do then? So we need granular data. So do we need fancy data? No. We just need granular data on clinical presentation, how patients are managed, what kind of drugs or what kind of surgeries they receive, and how do they do in terms of survival. Very basic stuff actually, right? But a lot of it is not currently available in our National Cancer Registry because, to be honest, National Cancer Registries are not usually capturing very granular data. They only have very basic information, especially in the low and middle income countries. So it's not that easy, but we could get there because there are some countries which are doing well. But we still need that sort of granular data, and how we will use the data is how I'm going to show in the next slides. But it's important because we have all our clinical practice guidelines. We don't know whether we are doing well with our clinical practice guidelines because our clinical practice guidelines are adapted guidelines. We don't just directly take clinical practice guidelines from, for instance, NCCN or NICE from the UK, and we have to adapt because we don't have the resources. So how is the CPG? Are we doing well? Our CPG is adequate? How do we enhance delivery of cancer care? How do you evaluate cancer policies that we currently have? So you might be wondering how with that simple data like clinical presentation, I'll show in a bit. And also, most importantly, based on that data and the interpretation, then you can use it for strategic allocation of funds. Where do I put my money? Do I put my money for primary prevention, trying to address, like all the risk factors? Do I want to beef up my early detection? Or do I want to, spend more money on cancer drugs? Or do I want to provide supportive care so that people actually stay in the treatment and stay within the healthcare system? So there's a lot of questions that policymakers need to answer, and this simple data can be useful. Can we go to the next slide? So what we did is we just did something very simple. People will call it audit. For a long time, people don't even think that this sort of word is research, but this is research. This is the kind of research that low and middle income countries need to do. Just look at how patients present. So we decided that we examined the trends on clinical presentation, management and survival of women who are newly diagnosed. So we want to look at different cohorts of women across a 15-year period. So the period, you can do 10 years even. All you need to do is the trends. Are we doing better? Are we stagnant? Are we deteriorating? Right? So the methodology, we just looked at hospital-based breast cancer registries because they have granular data. But the National Cancer Registry also has the capacity to move up and scale up to this level. So we looked at the University Malaya Medical Center's breast cancer registry, which is long-standing since 1990s. And then, of course, we also have our specialist wing in University Malaya. And the other place that we looked at is Samdadi Medical Center, Subang Jaya Medical Center. So we looked at all patients who were diagnosed from 2005 to 2009, 15 years, stage 1 to stage 4, and all newly diagnosed. And we had a passive follow-up until December 2022. We looked at overall survival, meaning that death due to any causes, and number 2, breast cancer specific survival with a inverted comma, because the breast cancer specific survival is, if you want to do that, you need the real cause of death. In Malaysia, it's still not possible to get because a lot of our deaths are not medically certified. But we use quite a good, nice, fancy analysis, especially for this one, which we call as net survival, which is actually a very good approximation of breast cancer specific survival. So we did that. And when we looked at our patients, we had 7,000 plus patients. This is Klang Valley. So the patient distribution is half from private, half from public. Pretty much sums up the scenario in Klang Valley and I think Selangor even. And then in terms of patient distribution, a vast majority were Chinese and about 20% were Malays and Indians and other races. This is the fact that the registries that were based here, the catchment area is reflective of the ethnic population, but also because of the age standardized rate where it's very high among the Chinese. So that's why we have like more Chinese patients. If we were to do this in HKL, we'll have 50% Chinese anyway. So, that's the ethnic distribution. Can we go to the next slide, please? So then we start looking, simple things. How have age and diagnosis changed? So if you just look at the median age where people presented, when I started my PhD, we did a similar exercise. At that time, the median age at diagnosis was 49. Now it's 53 years old. So that time was a lot of premenopausal. Now we have moved towards postmenopausal breast cancers being diagnosed. That's a very important point actually. And then when we looked at the median, it didn't change much. But when we actually started putting them in, groups, we see that we have more. Can you click? I think it doesn't. The model doesn't work because I have animations and I have to. So sorry about that, right? Okay, so if you look at the age distribution, we have more women who are above 60 being diagnosed now, and we have more premenopausal breast cancers, slightly higher but not much. Right? So we see that, I said premenopausal, I meant postmenopausal, but having more women diagnosed more than 60 years old is an important point to remember. I'll get back later. Right? And then the next one, please. Trends in cancer stage. Okay, this is something that we are really looking forward to. So when you look at the stage at distribution, you see from the first period where we divided women from 2005 to 2009, we have more patients who are presenting with stage 1 breast cancers. But it's very modest. You see it's not much. Can you take the next one? But when you look overall, you see that the advanced breast cancers are still pretty much making about 40%. You didn't see much difference. So yes, there's a slight increase in stage 1, but advanced breast cancers still make up 40%. That's an important observation again. The next one. And then, of course, when we looked at our patients, only 2% were screen detected. So all of them were presenting symptomatic to all these centers. They were not women who were diagnosed because they were screen detected. That is something alarming, because it's 2% throughout. It's not increasing. It's not like 2%, 4%, 6% or so on. It's 2%, 2%, 2%, right? And then when we looked at the tumor size, a bit of optimism. Can you click the lines, please? Okay. So you see that we see more women are presenting with smaller tumors, 2 cm or less. 2 cm is like, something you can feel. So we have women with smaller tumors, and then the number of women who are presenting with large tumors above 5 centimeters are decreasing. So although we didn't see that the stage, you didn't see much going on, but when you look at the tumor size, you see that there is some good news, right? And mind you, this is a registry which is based in Klang Valley, right? So just imagine how it will be elsewhere. 40% are advanced breast cancers. Can I even get the next one? Okay, this is another very important slide, because we want to know, because breast cancer is heterogeneous. It's not the same disease. We have different subtypes, and we see that the hormonal receptor positive breast cancers are increasing. Okay, so these are the good prognosis tumors. So they are increasing, and we see that likewise the HER2 positive or HER2 overexpressed breast cancers are reducing, the triple negative breast cancers are reducing. So that is again a good news. So it seems that they are more favorable, the tumor characteristics. The next one, please. Okay, so now we switch here and look at management. So this is like 20 minutes, right? I can't go in detail, but if you're interested, we can share the paper. So in terms of plans in the type of surgery, there are 2 main types of surgery. Either we remove the lung and give the women radiotherapy, or we remove the breast. So when we look at this, the mastectomy, right, from 70%, it has reduced to 60%. And this is early stage, stage 1 to stage 3A, right? And still mastectomy is the main type of surgery in almost 60%. That's also not what we see in the high-income countries. A lot of them actually have their lumps removed. That means they get to keep their breasts. So this is again a very important thing that we are, like, why is our mastectomy rate so high? So it warrants question, because then are we not having enough radiotherapy facilities that we are keep on giving mastectomy? But it cannot be, because this Klang Valley, all these centers have got radiotherapy. So are there other patient-related factors that we need to deal with? So that's a question, right? And then trends in radiotherapy administration, not much going on. A lot of the patients who are supposed to receive radiotherapy do receive. Its positive trend is about the same. So we don't see much going on here. And trastuzumab, another targeted therapy, expensive, life-saving. How do our women, what is the access that they get? This is for women with HER2 positive breast cancers, right? One thing that I wanted to note is previously when we compared survival between patients with HER2 positive breast cancer and triple negative breast cancer, we see that they all don't do well equally, because women who are supposed to get trastuzumab do not get trastuzumab. So are we doing any better? So when we look at 2005 to 9, only 5% of eligible women received trastuzumab. And then when we went on to the second cohort, 20%, and then the third cohort is 40%. There is an upsurge of use, also in stage 4 breast cancers, again, alluding back to the CPG. We used to not recommend trastuzumab in stage 4, not because it's not effective, because we didn't have resources. But now we see that more stage 4 patients are getting trastuzumab as well when they're eligible. Private hospitals obviously had higher administration rates, but the surge in use is more prominent in the public hospital. There's a 9-fold increase. And when we examine the dates, it comes to the third period where we started introducing generic trastuzumab. So policy, right? So when we started improving our generic, we allow generic drugs to come in, then we see access improve. And how does that relate? Can you go to the next slide? Okay, again, chemotherapy, not much going on, except we started using a lot more neoadjuvant chemotherapy. So that's also in keeping with the global trend. So we see a rise. Can we go to the next one? Yeah, next one. Click. Okay. So how are our women doing now in terms of overall survival? Can we click the next one also? So on one side, we have the overall survival, death due to any cause. And on the other side is breast cancer specific survival. So the blue line shows the most recent period, and we see that they are higher. So this is a Kaplan-Meier curve showing survival, and we see that is a trend in improvement in survival, and they are all statistically significant. So that's a good news, right? That's a good news. We also see in overall survival. We also see the same in breast cancer specific survival. Good news. Can we go to the next one? But it's very generic, so we have to still look at the different subgroups. Just click everything, yes. Okay. So when we look at stage 1, yes, we don't see much. It's the curves are all overlapping. There's not much we see. But when we look at stage 2, also not much. But in stage 3 and stage 4, you see that the blue lines are all above. They are all, which means that there is an improvement in survival as time goes by, right? So you see that in stage 3 and stage 4, it's all statistically significant because the Kaplan-Meier curves are separating, and they are all showing improved survival in women with advanced breast cancer. Good news, right? But we also need to look at the subtype of breast cancer, the next one. Okay, so hormonal receptor positive breast cancers. If we look at overall survival and we start comparing the different subtypes, hormonal receptor positive breast cancers remain with the highest survival because they are supposed to be good prognosis tumors. But when we compare the trends, is there improvement in when women have hormonal receptor positive breast cancers? Are women who are being diagnosed recently having better survival? We didn't see much going on. It's quite stagnant. So the trends in survival remains the same. But when we look at HER2 positive breast cancers, the one where trastuzumab is available, you see that the blue lines are all above, which means that in recent times, women with HER2 positive breast cancers are doing significantly better. So this is a take-home message from this slide. Triple negative breast cancers, nothing much going on as well. So one, HER2 hormonal receptor positive breast cancers still have the highest survival, but the trends are not, like you don't see something remarkable. But in HER2 overexpressed breast cancers, you see something remarkable, something going on. The next one. So let me summarize the things that we have seen, right? One, we saw more older women. I didn't put it up here. We have extremely low numbers of women with screen-detected breast cancers. And then advanced breast cancers still make up 40%. That's quite high, almost half, right? And then our women are presenting with more favorable tumor characteristics, more hormonal receptor positive, smaller tumors, and then we also have lower triple negative breast cancers, which generally have poor prognosis. There is an upsurge in use of neoadjuvant chemotherapy, and there is an anti-HER2 therapy use upsurge, but it's not good enough. And then there are significant improvements in survival, much more pronounced in stage 3, stage 4 breast cancers, and also in HER2 positive breast cancers. But there is a stagnant survival trend in women with hormonal receptor positive breast cancers, which is supposed to be the best cancer to have, like inverted commas again. So what do we do with our advanced stage breast cancer? So even in Klang Valley, if 40% of women in some of the top oncology centers are coming with stage 3 or stage 4 breast cancer, that is not something good. We are not doing well. So some of the things that we have picked up from elsewhere, from all over the world, right? Our campaigns, our messages we are not doing well, right? The traditional trend is we decide that this is what I'm going to do as my campaign, have it. But we have to co-create with patients and support groups and come up with more culturally relevant messaging. We are failing there. And then, of course, we need to improve access to healthcare. Clinical breast examination has shown some good news, especially in postmenopausal breast cancers. Can we use that for screening? That's the next question. Patient navigation programs are so important. We don't want these advanced breast cancers, right? So what do? Patient navigation programs work. So invest in them. Leverage low-cost technology. So I was attending a meeting on cervical cancer and we kept on talking about the low-cost technology that we have, which is MySejahtera. I don't know how many of you are fans. I am a fan simply because during the pandemic, it did help, right? So this is something to think about. Not about MySejahtera, but low-cost technology. How are we going to harness that for improving awareness and facilitating screening? Can I have the next slide? So, what is good and what can be better? I'll start with what is good. Smaller tumor sizes, does it mean that our literacy is improving? A question, right? And there is overall improvement in survival. So it seems that our cancer control efforts are working. We are doing well, but can we do better? So that's the next question. And then we see that increased access to trastuzumab. So biosimilars are doing well, but how do we improve further? Not only trastuzumab is just one example. What about in other drugs? And the stagnant survival trends, there's lack of access to newer endocrine therapies. I think that's the example. Most of the women are getting tamoxifen. So we have to address the cost concerns and try to improve biosimilars. I think that I'm pretty much done. And this is a cancer registry from Klang Valley. So the next question is, are we all optimistic? Anyway, this is like a wake-up call. If we are doing that at this level in one of the top, like most affluent region, what about other parts of the country? So we do see encouraging breast cancer trends, but we can certainly do better. So thank you so much.